Sushruta LGS. I am Dr. Neel. In today's video, we will be continuing the topic of nerve compression syndromes. Last time I discussed about median nerve. Today I will be talking about ulnar and radial nerve compression. So ulnar nerve can get compressed at two places. One is the Guyane canal, which is present at the wrist, and second is the cubital tunnel, which is present at the elbow. So starting with the Guyane canal compression, this canal is formed by the roof is formed by the volar carpal ligament, also known as palmar carpal ligament. The floor is formed by the transverse carpal ligament. Ulnar border is formed by the pisiform and the pisohamate ligament, and the radial border is formed by the hook of the hamate. So you should know that the median nerve, it passes underneath the transverse carpal ligament, whereas the ulnar nerve, it passes above the transverse carpal ligament and then it enters the Guyane's canal. So when the ulnar nerve is present in the forearm, so just at the wrist level, it will be present beneath the FCU. This is the FCU tendon, which is getting inserted at the pisiform, and when it comes near the pisiform, it turns radially and it enters the Guyane's canal, and then it passes in the hand. In the Guyane's canal, ulnar nerve divides into superficial sensory branch and the deep motor branch, and it is accompanied by the ulnar artery. It can get compressed in Guyane's canal due to various reasons. There can be mass lesions like ganglion, which is one of the commonest reasons. There can be hook of hamate fracture or pisiform fracture and dislocation. There can be a giant cell tumor, ulnar artery thrombosis, which occurs due to repetitive trauma, or ulnar artery aneurysm. Sometimes the cause is not known, which is also known as etiopathic. In presentations, patient will have distal ulnar deficits. It can be both motor and sensory, depending where the ulnar nerve is getting compressed in the Guyane's canal. So in zone 1, that is before the division of the ulnar nerve into sensory and motor branch, so patient will complain of both motor and sensory deficit. In zone 2, only the deep motor branch gets compressed, so patient complains of only motor deficit, and in zone 3, only the sensory branch gets compressed, so patient complains of sensory deficits. Tinel signs may also be present, and worsening of symptom will occur if we give direct compression over the Guyane's canal. Treatment is surgical for this compression. We have to divide the palmaris brevis muscle or the palmar carpal ligament, or we have to remove any offending mass like ganglion, or if there is any fracture, we have to treat it. Any offending mass in this region needs to be removed. Now coming to the cubital tunnel syndrome. Cubital tunnel is a tunnel which starts from the medial epicondyle of the humerus up to the FCU. So this is the medial epicondyle of the humerus, and this is the FCU, two heads of the FCU. So the ulnar nerve, after it leaves the distal arm, it passes beneath the Osborn's ligament. So Osborn's ligament is a fascia which is present between the olecranon process and the medial epicondyle of the humerus. This is the Osborn's ligament. Osborn's ligament, it forms the roof of the cubital tunnel. Ulnar nerve mostly gets compressed in this region. It can also get compressed beneath the arcade of Struthers. So this is the arcade of Struthers, which is present in the distal arm, and it is present between the medial head of the triceps and the medial intermuscular septum. So this is second region where the nerve can get compressed. Cubital tunnel is the most common reason of compression of the ulnar nerve. And lastly, ulnar nerve can also get compressed in between the two heads of the FCU. So you can see this is the Osborn's fascia. Osborn's fascia, it is present between the two heads of the FCU. So our ulnar nerve is passing beneath the Osborn's fascia, that is in the cubital tunnel. Okay, this is the arcade of Struthers, as I explained before, present between the triceps and the medial intermuscular septum. Okay, so cubital tunnel region is where, as I said, is the most likely region where the ulnar nerve is getting compressed, and motor and sensory symptoms, they develop in the distribution of ulnar nerve, and they are worsened when patient adopts a flexed position at the elbow. Okay, Ulnar nerve, which supplies the FCU and the medial two heads of the FDP, that is FDP of ring and little finger. So again you will have deficit of the FCU muscle and those FDP tendons. Examination, there will be tunnel sign. When you percuss over the tunnel, you will get tunnel signs. There will be paresthesia in the distribution of the ulnar nerve, that is the little and the ulnar half of the ring finger and the ulnar border of the hand. There are few differential diagnoses like thoracic outlet syndrome or compression of the ulnar nerve in the Guyon's canal or nerve root compression in the neck. Treatment is, if it's an early stage, you can just splint the elbow in extension at night, or you can use soft extension elbow pads which will prevent elbow flexion and prevent direct pressure over the nerve. But if you feel that the conservative measure is not working, there is failure and there are significant changes in the electrodiagnostic studies, you need to go for surgical decompression. In surgical decompression, all the fibrous restraints around the ulnar nerve and the elbow, they are released and the nerve is transposed anteriorly in the subcutaneous or the submuscular plane. So it depends on patient to patient whether we want to do it in the subcutaneous or submuscular plane. Endoscopic decompression of ulnar nerve is also a modality which can be considered. Now coming to the radial nerve can get compressed in the triangular space in the axilla. So this triangular space, it is bounded by the humerus bone laterally, by the long hair of the triceps and by the teres major muscle. So it can get compressed in this region. Secondly, it can get compressed in the spiral groove which is posterior to the humerus in the arm or lateral intermuscular septum proximal to the elbow. So once it exits the triangular space, it passes in the spiral groove which is posterior to the arm, then it pierces the lateral intermuscular septum and comes in the anterior compartment. More distally in the forearm, now the radial nerve gets divided into posterior interosseous nerve and the superficial sensory branch. Posterior interosseous nerve is the principal motor division of the radial nerve, which gets compressed in the radial tunnel. This radial tunnel is a tunnel which is present in the proximal forearm just distal to the elbow. Okay, it starts from the radiocapitellar joint up to the supinator muscle. Okay, so the radial nerve can get compressed in this region due to ligament or arcade of Frost. This is the fibrous edge of the supinator muscle. It can get also compressed due to the leash of vessels, also known as leash of Henry, or fibrous tissue anterior to the radiocapitellar joint. So this will cause variable degree of interosseous nerve paresis or pain radiating down to the dorsoradial aspect of the forearm. It is also known as radial tunnel syndrome. Initial treatment is again non-operative. You can just splint. If it does not improve, then you have to go for surgical decompression. Another term which you need to remember is Wartenberg syndrome, where the superficial branch of the radial nerve gets entrapped between the brachioradialis and the ECRL. So patient will have symptoms, paresis, paresthesia on the dorsum of the hand, on the radial aspect of the hand. It will specifically occur due to forearm pronation and repetitive wrist flexion. One important term another is Wartenberg sign. Don't get confused. Wartenberg sign is seen in low ulnar nerve palsy where there is abduction of the little finger. That is Wartenberg sign. This is Wartenberg syndrome, where the superficial branch of the radial nerve is getting compressed. So I hope I have made the topic of nerve compression syndrome pretty clear to all of you. In case of any doubt, you can contact me. Feel free to ask any questions. Thank you.